Without any further delay, I would like to invite Dr. Purvish Parekh, Group Oncology Director and Professor of Medical Oncology from Shalby Cancer and Research Institute, Mumbai, and Dr. Bharat Parekh, Senior Consultant Medical Oncology, HUC Vedanta, Ahmedabad, to chair the session on molecular oncology. And for this first speaker session, I would like to invite Dr. Harsh Sheth from Ahmedabad to talk on NGS, what a clinician should know.
At the back? Excellent. So let me just briefly introduce myself. My name is Dr. Viraj Lavingia. I'm an assistant professor and head of advanced genomic technology solution at Foundation for Research in Genetics and Immunology, which is based in Ahmedabad. I have primarily worked at Newcastle University, UK, where I did my PhD and postdoc. Thank you. And I have worked in the area of colorectal cancer prevention, Lynch syndrome, male infertility, and pharmacogenetics. During that period, and even now, I collaboratively work with Newcastle University in the UK, Newcastle University in Malaysia, and University of Gajah Mada on MSI testing, about which I'll be talking briefly today. I also receive research grant support from UK Medical Research Council and Gujarat State Biotechnician. And I would like to disclose that I'm a co-inventor on 2 patents describing NGS-based MSI-SA, which I'll be describing very briefly. Now, I presume I know everybody knows about NGS briefly, and we know that it's used in the area of identifying either germline mutation or somatic mutation. Is that right? Right. But what if we want to look at a specific molecular pathology of a tumor? And to answer that question, I'll be taking colorectal cancer as an example. Now, as you can see, there are 2 ways to reach from a normal epithelium to a metastatic colorectal cancer. You either have the familial adenomatous polyposis pathway, whereby you get a lot of polyps in the colon, and it starts by mutation in the APC gene, and then a whole set of genes are dysregulated along the pathway that leads to your chromosomes going all wacky. And that happens in about 5 out of 6 patients that we see in the clinic. In 1 in 6 patients, we get mutations in one of the mismatch repair genes. And these are the genes that are involved in repairing small mutations that occur across your genome. And when these get knocked out, a whole bunch of pathways get activated, due to which a lot of mutations get accumulated in your genome. And about half of these patients have BRAF mutation in them. And patients who don't have BRAF V6 mutations, they're likely to be Lynch syndrome carriers. So BRAF kind of acts like a strategic stratifier of patients, whether they are Lynch or non-Lynch. Now, Lynch syndrome, everybody has heard of it, so I'll very briefly go through it. It's patients who are Lynch syndrome carriers are at risk of multiple cancers at a very early stage. These may primarily be colorectal cancer, endometrial cancer, or upper GI genitourinary cancers. And this is primarily caused by one of your alleles in one of these 4 mismatch repair genes getting knocked out. There's also one more gene, EpCAM, out here, which if it gets knocked down, you are predisposed to Lynch syndrome. Now, if you are a carrier of mutation in one of these 4 genes, then your lifetime risk of getting either colorectal or endometrial cancer is very high. So by the time you reach the age of 75 years, at least 1 in 2 patients will have a cancer. So clearly, identifying these patients very early on is the key. Now, currently, this is the pathway I presume you all employ for identifying these patients. To say a patient with primary CRC tumor comes into the clinic, so well, you offer them MSI testing or immunohistochemistry of 4 mismatch repair proteins. If they're microsatellite stable, or they're normal, or they have normal staining for all the 4 proteins, well, then they have microsatellite stable tumor, and you don't need to do anything more than that. But if they have microsatellite instability, then you either offer them BRAF testing or MLH1 hypomethylation testing. And if they have no mutation or their MLH1 is hypomethylated, well, then you then offer them the germline mismatch repair gene testing, which then leads to identification of whether they are Lynch syndrome carriers or not. So that's a pretty lengthy pathway to answer a very simple question. Now, we all do microsatellite instability testing day in, day out, but very few people may actually know what microsatellite is. So I'll just briefly explain what they are. Well, our genome is made up of 4 letters, A, T, G, and C, and they're randomly spread out across the genome. Now, there are places whereby you have a string of same letters occurring again and again. Now, they may be just a single letter, like this T, 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 occurring, or you might have 2 letters occurring in tandem. They are either called mononucleotide or dinucleotides. But essentially, this is what a microsatellite looks like. So when we do, when in a normal cell, your DNA polymerase comes along whilst making a copy of your DNA, it either removes a T or adds a T. That is a mutation in itself if it goes unrepaired. So mismatch repair system comes along, it repairs them, and voila, you're fine. But if one of these 4 mismatch repair proteins are affected, then you can't repair these errors anymore. And you start accumulating errors in your microsatellite, and this is what is called microsatellite instability. Now, not only in India, but across the world, for all colorectal cancer patients, it is recommended to carry out microsatellite instability testing using MSI, PCR-based assay, or immunohistochemistry to identify Lynch syndrome patients. Now, like I said, there are 2 methods to detect it. One is immunohistochemistry, but one way to look at it is pathologists who are highly trained. They're more or less like people who used to use bow and arrow. They're highly trained, they're very good at looking at things, but it's laborious from time to time. Because if something is there, it's very faint, you don't know what the answer is. The other technique is fragment length analysis, or what we routinely call MSI by PCR. Now, people who employ this, like myself, we are more or less like people who used to use guns back in 1800s. We could just point a gun and shoot. It wasn't very accurate, but you could get more hits like this way. But like I said, both of these techniques have some limitations to them. Well, the simplest one is they require manual interpretation. Even something like MSI by PCR can become very tricky to analyze. And due to this, you have inter-operator discordance. And because of all of these issues, they're not amenable to high throughput. And because of that, your cost per sample is not affordable in low-income country settings like India or Indonesia or Philippines or Pakistan or whichever low middle-income country you can take. Now, because of that, it is estimated that currently there are 3 to 4 people per 1,000 people in the population who carry mismatch repair gene defects, but only less than 10% of those people are known to medical services. So there is a whopping number of Lynch patients out there in the population that we haven't even recognized yet. So clearly, there's a need for a high-throughput, automatable, cost-effective MSI assay. More or less like a machine gun. You simply point and shoot, and it just shoots bullet left, right, and center. So, over the past 5 years, me and a team based in Newcastle have been working towards developing an NGS-based assay, which kind of ticks all boxes. But rather than looking at microsatellites that are 20 or 25 letters long, we only look at 7 to 12 letters long, because they are something that can be sequenced easily on your sequencing machines. And we do 2 clever things with it. One, we look at how many letters have been either incorporated or deleted in those microsatellite regions. We count them up. And the second thing we see is whether those deletions or additions have happened on just one allele or on both alleles. And if they have happened on both alleles, then it's quite likely a technical artifact coming from PCR or your sequencing machine, or if it's happening on a single allele, then it's quite likely to be a genuine mutation. So, based on that, we created a Bayesian method that could give an automated scoring system to every single sample. And that's exactly what we did. We took 100 patients and we analyzed them using MSI by PCR, and then we sequenced them up in a blinded fashion. And voila, what you see are patients in red who are MSI high. Patients in blue are MSS. They're called by MSI by PCR. And look, we get a very clear separation using our method. We then analyzed another bunch of 100 patients, and we screened them again with our technique, and we got 100% sensitivity and specificity. Now, initially we had a pool of 24 markers, but we managed to shrink it down to 6 markers, and again, we could have 100% sensitivity and specificity, suggesting that our panel has some level of redundancy in it. We have also incorporated BRAF, V600E, and KRAS codon 12 and 13 mutations in the panel at no additional cost. And the workflow is extremely simple. You get your results very, very quickly. Now, because it's a sequencing-based assay, like any sequencing assay, it's amenable to high throughput. And because the analysis is automated, nobody has to sit in front of the screen and look at squiggly peaks. The other thing that we have also incorporated is that because we look at polymorphisms in the DNA, we can actually provide an internal quality control to ensure that you don't mix up samples. Now, this entire analysis is published in Human Mutation. It just got published a couple of months ago, and we have got 2 worldwide patents on it. Now, as we all know, the applicability of this assay in routine practices has many implications. You can provide information on prognosis. You could provide information on immunotherapies, whether they'll respond to it or not. You could think about surgical options, whether you want to go for hemicolectomy or full colectomy. Or partial colectomy. And actually, you could also think about chemoprevention of cancers in Lynch syndrome carriers. And this is something I'll come back in just a minute. But coming back to India now, right now, nobody in India knows the incidence or prevalence of either MSI or Lynch syndrome in colorectal cancer patients, which is extremely sad. So we applied to the government and we got funding. And I'm glad to say I'm the PI on this grant, and my co-PIs are Dr. Abhinav Jain and Dr. Bhavish Thakkar at SIMS Hospital. We are going to be screening primary CRC patients up till 2022. We'll be doing our MSI assay, BRAF testing, and germline mismatch repair testing completely for free of cost to the patient, and we'll be giving them report. This is first of its kind study in India, and it will be critical for preparing care pathways and cancer prevention strategies. So if anybody wants to collaborate, you're more than welcome. Sorry? To Lynch. So, I'm so glad you mentioned about Lynch, because that's exactly what I'm going to talk about. Back in 1994, my supervisor, Professor John Byrne, along with his 2 colleagues, started looking at whether aspirin could prevent colorectal cancer in Lynch syndrome carriers. And fast forward to 2011, they conducted a randomized control trial where they had given 600 milligrams aspirin a day for 2 years, and then they followed them up for 5 years. They found that they reduced risk of colorectal cancer by 50%, which is fairly whopping. But then we thought, what if we follow them up for 20 years? And this is the data that just came out this year. Please don't take any photos of this. This is unpublished data. And as you can clearly see, the blue line is placebo, the red line is aspirin. Even after 20 years of follow-up, and remember, they had only taken aspirin for 2 years, we still get 40% reduction in risk of colorectal cancers and other Lynch syndrome cancers as well. Now, we have written up the manuscript. We are just about to submit it to Lancet, so you will see this analysis very, very soon. So, to summarize, MSI or mismatch repair deficiency testing is extremely important, and you find these phenotypes in 1 in 6 colorectal cancers worldwide. But the problem is we don't have the information on incidence or prevalence in India currently. Well, we're working towards it now. NGS-based MSI assay could potentially streamline Lynch syndrome testing in solid cancers, especially in colorectal cancer, with an assay like this that already does MSI as well as BRAF in a single run at no additional cost. That's very, very good. we have shown that regular intake of aspirin reduces risk of colorectal and other Lynch syndrome cancers. Ooh. Oh, I can see it. Right. But we'll be giving you 20-year follow-up data very, very shortly. So please stay tuned for that. And lastly, we are piloting our NGS-based MSI testing in India. Anybody who wants to collaborate is more than welcome. I would like to acknowledge all these wonderful people in India, as well as across UK, Indonesia, and Malaysia. And lastly, I would like to thank the wonderful organizers, especially Dr. Viraj Lavingia, for inviting me to this conference, and thank you all for listening. Ooh, and I have 10 seconds left. Yes, please.
Are you aware which company does hypermethylation test in India right now?
So, hypermethylation.
Yes.
There are many commercial vendors.
In India?
Yeah, they do provide that.
We have core, yes, doing it. Because last meeting I was told in India we don't have hypermethylation test. We're doing it. Okay.
We do hypermethylation testing, but BRAF-V600V can act as an alternative to hypermethylation.
So if BRAF is not, so BRAF is wild type, then you need to do hypermethylation, right? MLH1.
Yes. There are two caveats to this. If you have done immunohistochemistry and your MLH1 is knocked down, for example, then you can straight away do hypermethylation testing, right? And that gives you a clear-cut answer. But if you've either done MSI by PCR or if you have done an NGS-based assay, then there's no need to do hypermethylation testing because you
only applying for IHC.
You probably do it in IHC pathway, yes. Yes, sir, that's absolutely right. Yes, sir. Daily, given for 2 years. These were patients who followed the protocol. So these were per protocol analysis results. We have incidence, we have intention to treat analysis results as well, and they're equally comparable.
Any side effects that you can mention of 600 milligram aspirin daily for a long period of time?
Right. So in the trial, these participants were fairly young. They were the mean age was around 42 years, right? They were given aspirin intervention for a very small time, and we didn't see any substantial or statistically significant increase in side effects compared to the placebo group. But I absolutely understand your point why you would have reservations for 600 milligrams a day, and I'm quite glad to say that there is a follow-up trial of this. This trial name was CAP2, so the next trial's name was CAP3. Well, they were not very imaginative with the name, but what they're trying to do, it's a dose inferiority trial. So this time they're comparing patients who've got 600 milligrams, 300 milligrams, and 100 milligrams a day. And they're asking two very simple questions. Can we get the same response from 100 mg aspirin? And second, are there any lesser side effects if you take 100 mg aspirin compared to 600 milligrams?
So, same concern that do you have a data that how many percentage of patients dropped out of this high dose? Because if I remember, there is one large Canadian trial which is done probably 60 milligram and twice a week. And they had observed not a very large incidence, but some intracranial hemorrhage was observed in their studies. So with this, do you have any data?
When the study started back in 1994, I think the last recruit came in 2004, right? Back then, a lot of studies showing challenges of aspirin and all the side effects were not so prominent. So we didn't see such a massive dropout then. But yes, in CAP3 trial, we do see some level of dropout. And it's quite funny. Anytime a negative article comes in the BBC, for example, you suddenly see a spike in dropout rate, and then it flattens out. Because just a couple of days later, there's a second article saying, look, you get a benefit of taking aspirin, so why you are not taking it? And the other thing, there is a latest trial. It's called the ASPRI trial that recently came out. And it was done in extremely old people. And what they managed to show is that if you're very, very old, or if you're extremely obese, you'll more likely get a side effect from taking aspirin, and you'll get no positive effect at all. So Lynch syndrome is actually a very interesting group in that sense, because you want to prevent cancers early on, so you are more likely to give them aspirin probably at the age of 20, 25, right? So they're more happy to tolerate it overall.
Can you guess what is the mechanism of action of aspirin in terms of prevention?
Yes.
Where does it act?
I'm so glad you asked, because that was also part of my PhD. So, aspirin overall is a very dirty drug because it affects multiple pathways. You can think of the cyclooxygenase pathway, you can think of NF-kappa B pathway, and there are other ODC1 pathway as well that it affects. And actually, the only thing that we can say for sure is that because Lynch syndrome is so immunogenic in nature, it's quite likely that the majority of the effect comes from the cyclooxygenase pathway, because that's the immune suppression pathway, right? And it creates immune system around cancer, especially in Lynch patients. But beyond that, the other likelihood other pathways might be adding some effects, although they are not quantifiable.